So it really gives me a great pleasure to introduce the following session on women and bleeding disorders. It would only seem appropriate, given the new partnership with the SOGC, that I would have a few minutes to call upon before opening the session Dr. Vida Senekes, who's the Executive Vice President of the SOGC, who's here today, who's a professor of obstetrics and gynecology at McGill University. And on a very personal note, and she knows this, she was probably the funniest teacher I ever had in McGill. And she actually gave us the course on sexual education and made us all laugh to tears. Dr. Senekes.
Thank you very much, Dr. Winikoff. I can't tell you how pleased that SOGC is to have been invited to this first inaugural conference. As you all know, SOGC represents some 4,000 members, where our mission statement is the improved reproductive health of Canadian women. And I must say, looking at the ambassadors, listening to what I just listened to as an obstetrician gynecologist, I am humbled at the message that I heard here. And I can only tell you that SOGC's commitment in partnership with CHS will look forward to addressing these issues. The issues are particularly ones of awareness. If you look at SOGC, we represent a collaboration between obstetrician gynecologist, family practitioner, nurse, and midwife. And it is with this type of collaboration. We have subspecialists as well, the pediatric, who have a group called CanPago. With this type of awareness raising, where indeed an early diagnosis can be made, where case after case I heard here involved either a menstrual period, an ovarian cyst. We have a very active website, Sexuality and You, where we would be more than pleased to incorporate material on that awareness so that when a woman presents before any one of these healthcare providers, that depending on the symptomatology, the right questions are asked, the diagnosis is made at the right times, and certainly one can go forward sparing some of the very endearing issues that I've just heard. I look forward to the participation today. I congratulate you all, and I particularly congratulate HSC in this going endeavor. Thank you very much.
Thank you very much for those most inspiring words. It's a great pleasure to start the session and to open formally the session on management of bleeding disorders in women. I'd like to call upon our first speaker, Dr. Paula James, who is the medical director of the Southeastern Ontario Inherited Bleeding Disorders Clinic in Kingston. Dr. James is currently an associate professor in the Department of Medicine at Queen's University with cross appointments to pathology and molecular medicine and pediatrics, and is a clinician scientist with a research interest in inherited bleeding disorders. In November of 2011, she was awarded Researcher of the Year by the National Hemophilia Foundation of the United States. It's no greater pleasure to introduce my colleague and friend, Dr. Paula James.
Thanks so much, Rochelle. And I want to thank you and Claire for your significant efforts in organizing today. It's a real pleasure and a privilege for me to be involved. And so my task in the next 20 minutes is to talk about lab diagnosis of von Willebrand disease and to address some of the issues of geographic lab location and transport of samples. So I'm going to start with a bit of history. We've actually already seen this picture today. This is Dr. Eric von Willebrand, who described Kouides, who bled to death at the time of her 4th menstrual period. She'd nearly died once earlier when she was 3. She bit her tongue and essentially went into a coma and spent a significant amount of time in bed. She and her family lived in this fairly remote area, and he had studied a number of her family members and wrote this paper. And so this is the original description of von Willebrand's disease that was published in 1926. And it's actually a brilliant description of the suffering that patients with bleeding disorders go through. What I've highlighted on this slide was what he had available to him in terms of lab diagnosis. And this is awesome. So he had basically a CBC. He had some blood counts. So he knew what the platelet count was. He had a bleeding time, which is not sensitive, nor is it specific for milder forms of von Willebrand's disease. And he also had this test called the coagulation test on a watch glass with 20 big drops of blood. That's awesome. And he basically described the formation of the clot and whether the clot retracted. I'm delighted to say that this is not how we diagnose von Willebrand's today. And I'm going to show you how far we've come in terms of being careful and accurate with this diagnosis. And a couple of years ago, I actually had the privilege to go visit the Åland Islands, and this is the gravestone of the index case with von Willebrand's disease. So Kouides, who we heard Christine Lee speak about on the video at the beginning, is here. And as has already been mentioned, we know now that she had type 3 von Willebrand's disease. And I think one of the messages today is how far we've come. We still have improvements to make, but this kind of tragic death doesn't need to occur anymore. So I have to start with a little bit of basics about von Willebrand factor, and I'm going to keep this fairly simple. We make von Willebrand factor in our endothelium, and we also make it in megakaryocytes, and it gets stored in Weibel Palladi bodies in our endothelial cells, and that's what I've shown on this picture here. This is a blood outgrowth endothelial cell, which you actually can get from a peripheral blood sample. And the green granules are von Willebrand factor. And they're localized within Weibel Palladi bodies. And that storage is critical for treatment, because if you give desmopressin, what happens is those granules release that store of von Willebrand factor into the circulation. There's also a store of von Willebrand factor in alpha granules of platelets. And von Willebrand factor is critical for a couple of key roles in hemostasis: platelet adhesion to sites of vessel injury and aggregation. And it also carries and protects factor VIII. And I think that there's often confusion about the difference between von Willebrand's disease and hemophilia. And I think of them as cousins, with this relationship between von Willebrand factor needing to be there and needing to function properly in order to carry and protect factor VIII. So von Willebrand's disease is caused by a lack or a dysfunction of von Willebrand factor. And if you look at some historic papers that reported how frequent it is, there are some older papers that reported a prevalence of about 1 in 100. And I think that the important message is that this is common. I think 1 in 100 may be a bit of an overcall, though, and what I think is more important is how many people suffer with von Willebrand's disease. And that number we've actually heard a couple of times already today. It's probably more like 1 in 1,000. It's inherited autosomally. This is not sex-linked like the hemophilias. And what that means is that men and women are at risk of inheriting this if they have an affected parent at equal rates. But because of the symptoms of menorrhagia and bleeding after childbirth, we diagnose more women than men at a ratio of somewhere around 2 or 3 to 1. And so as I start into the part about lab diagnosis, I just want to make the point about why is diagnosing von Willebrand's disease carefully so important. And we've already heard this discussed today. If you look at a symptomatic prevalence of 1 in 1,000, there are probably at least 34,000 people in Canada who are suffering from von Willebrand's disease and are symptomatic. And if you look at the number of patients that have been diagnosed and are registered in clinics, it's actually an appalling fraction of that, maybe 10%. And so there are thousands of people in this country who have von Willebrand's disease and who don't know it. And the symptoms are treatable. And so one of the messages about the importance of accurate diagnosis is making sure that those patients have access to care. The opposite problem, though, is also real, which is diagnosing somebody inappropriately who may actually have a different bleeding disorder, and we've heard already today about the problem of misdiagnosis. If you diagnose somebody with von Willebrand's disease and they don't have it, you've labeled them with a genetic diagnosis, and that has implications for their family members. There may be treatments that that patient is exposed to that are wrong or unnecessary, and there may also be limitations on lifestyle that aren't required. And so we need to identify patients who have the disease and not misdiagnose those who don't. And so I want to acknowledge Megan DeForest and David Lillicrap, who helped me and also Claire Caccini put this together, and all of you received this in your bags. So this is a really brief guide about how to diagnose von Willebrand's disease, and I'm going to use it as the framework for the rest of this talk. I think we need to consider the diagnosis of von Willebrand's disease in anybody who has concerning signs or symptoms. And by that, I mean people who have excessive mucocutaneous bleeding. One of the problems, I think, is understanding exactly what the difference is between normal bleeding and abnormal bleeding, because we all bruise and we all bleed if you hit us or cut us. And I think bleeding scores or quantitative ways of assessing bleeding have helped us understand how much bleeding is normal and what's outside of normal. And I'm going to talk in another slide or two a bit more about the bleeding score that we worked on in Kingston, and you have that in the guideline as well. We also need to consider the diagnosis for anybody who has an affected family member. And based on the inheritance for most of the subtypes of von Willebrand's disease, if somebody has a first-degree relative, that individual has a 50% chance of also having the disease. And so it's really important to be aware of that in families. And it's critical, therefore, to test the appropriate patients. This is the bleeding score that we have the most experience with and is in your guide. It's a summative bleeding score where the points earned for each bleeding symptom are added up to come up with an overall bleeding score. It has to be administered by an expert, so a physician, a nurse, a researcher who understands bleeding. There's a range of possible scores that's quite wide, from -3, and I'll explain the minuses in a second, to +45. We've studied this in 100 normal adults and in about 150 normal children. And we know that if an adult has a bleeding score of greater than or equal to 4, or a child has a bleeding score of greater than or equal to 2, that's abnormal. That's outside of the reference range and requires attention. And for anybody who's interested, there's more information about our bleeding score on our lab website. This is basically what it looks like. There is a questionnaire that comes along with it, which is about 7 pages, and it walks you through each of these questions. Once you're familiar with how to do this, you don't actually need that. All you need is the scoring key. When you're taking a history from the patient, you ask about all of the symptoms along the y-axis here, so nosebleeds, bruising, the things we've heard lots about today. And then each row, each of those symptoms is given a score. And so that row gets a 0 if a person hasn't had a problem with nosebleeds. And you go through each of the rows, and I'm going to just go through dental extraction as a specific example to tell what those minus scores mean. If somebody's had 2 teeth pulled by their dentist and hasn't bled, you take a point off the overall score, and it's a way of reflecting the balance of hemostasis. If that person has had dental extractions with excessive bleeding but didn't have to seek medical attention, they would get a 1. If they had to seek medical attention, they would get a 2. And then they would get a 3 or a 4 for that row with increasing levels of medical intervention, so resuturing or packing or a blood transfusion or factor replacement. And that's basically the framework for the entire questionnaire. And so very quickly, you can actually go through in about 5 minutes and calculate a bleeding score. And the reason I think this is useful is because we've prospectively validated this for people presenting at the level of primary care. And so we did this in family docs' offices. And anyone who came in and had a problem with excessive bleeding or bruising, we used the bleeding score and tested them all for von Willebrand's disease. And what we found was that it's very sensitive. And so It picks up individuals who have von Willebrand's disease very well. The other thing it does, though, is the negative predictive value is essentially perfect. And so if somebody has a negative bleeding score, it's extremely unlikely that that individual has von Willebrand's disease. And I think for the level of primary care, it can be a very useful tool to decide, okay, well, the bleeding score is normal. I don't necessarily need to go on and do additional investigations or refer, or this patient has a bleeding score of 7. They have to be investigated further. And just to talk about children, because our original study focused on adults, we did some work with Margaret Rand and Victor Blanchette from the Hospital for Sick Children, where we took our condensed bleeding score and modified it for children, and then prospectively tested that to see how well it worked. And it works reasonably well. One of the issues is that children may not have been exposed to the same number of hemostatic challenges as an adult. And I totally appreciated and think we all need to take the point that was made earlier by our ambassadors about paying attention to those small symptoms in children, bruising, nosebleeds. Those things actually will give you a positive score if they're there, and they need to be paid attention to. The negative predictive value, when we studied this in children, was also very good. And this included young children as well. And so those symptoms of bruising, bleeding when they lose teeth, nosebleeds really need to be paid attention to. In terms of the initial lab workup, the tests that I have listed on this slide are widely available. Most labs will be able to do this set of tests, so a complete blood count. And sometimes what you might see is an anemia, and it's typically microcytic because of iron deficiency. You may see thrombocytopenia if the patient has 2B von Willebrand's disease, but you may see a completely normal CBC. The PT is usually, the prothrombin time is usually normal in von Willebrand's disease, and the PTT is often normal but can be a little bit prolonged if the factor VIII level, because of the lack of chaperoning by VWF, has decreased. The really important point, though, is that these screening tests, if they're normal, do not rule out von Willebrand's disease. You have to go on and specifically test von Willebrand factor in order to rule out or rule in the disease. And so these are the initial tests that we would do when we're looking for von Willebrand's disease. We would do what's called the von Willebrand factor antigen, and that's an ELISA. It's a test that tells us how much of the protein is there. Then we do a functional test that tells us how well that protein works to stick platelets together, and that's the ristocetin cofactor, or Winikoff, as we often call it. And then because of that relationship between VWF and factor VIII, we always check factor VIII as well. These tests are available in most special coagulation labs. Most centers that have an inherited bleeding disorders clinic can do these tests, and a number of other hospital labs can do these tests as well, but these are not widely available. And so often what happens is samples may get drawn in one center and transported to another center for testing. I think if you have access to reliable results for this panel of tests, it may be reasonable to do them before referral. But if you have a problem getting accurate results, I don't think there's any point, actually, in doing these tests. And it's important for physicians to ask questions about the lab they're using and how these tests are done. It's also really important that you get an experienced interpretation of the results, because von Willebrand factor and factor VIII levels can be affected by a number of patient and sample factors. Patients, when patients are under stress, von Willebrand factor levels go up, and it's probably something we've evolved to do, that if we were being chased down by a lion and then the lion caught us, our coagulation factor levels go up to keep us from bleeding to death. We still do that. So excessive crying, which can be a major problem for young children. If a child is upset and crying and has to be held down for the test to be done, we can get false negative results. You can get normal results that don't actually reflect what the baseline levels are in that child when the child isn't crying. Acute illness, any kind of infection, the neonatal period, so testing babies can actually be misleading. You often get normal levels up until about 6 months. Exercise, which is similar to that stress response, increases von Willebrand factor level. It's actually a useful point for treatment, that regular exercise actually really does improve this disease. And estrogen, so the oral contraceptive pill, being pregnant, being on hormone replacement therapy, increases von Willebrand factor levels. And so if I get a patient referred and I see her for the first time while she's pregnant, I can't rule out the disorder, because if I get normal levels, it may be because of the estrogen effect in pregnancy, and you've got to retest again after. Our von Willebrand factor levels go up as we age as well. And there are some endocrine and immune problems that decrease von Willebrand factor levels, problems with low thyroid and anti-VWF antibodies, which can give a syndrome of acquired von Willebrand disease, also will lower the levels. There's an issue with ethnicity that's important to know about. African Americans tend to have higher VWF levels than what is often reported as the normal range. And there's a tendency to lower ristocetin cofactor levels. And the reason for that is because many African Americans have inherited a genetic change, a polymorphism, that affects ristocetin binding, causes low Winikoff results, but doesn't actually affect VWF function. And so there is a risk here of getting discrepant ratios between the function and the amount of protein, and getting suspicious about a qualitative form of von Willebrand disease. And so that's important to know about. Sample factors, I've alluded to this a couple of times already. If blood gets driven down the highway and isn't dealt with and separated into plasma before that happens, or if it gets transported at the wrong temperature, you can get abnormal results. And so samples should be processed within 2 hours. They need to be, if it's the whole blood sample, it needs to be transported at room temperature. If it's already been separated into plasma, it has to be frozen at -40 or below, and it has to be kept at that temperature until you're ready to run the test. This is a major problem in Canada. We've got a big geographic country with only a few labs that can do these specialized tests, and this is really an issue. The risk is that you're going to get false positive results, and so as I mentioned already, you need to know your lab, and you need to know what kind of attention is being paid to these issues. So if you have abnormalities in that screening panel, those first 3 tests of von Willebrand factor, you would go on to specialized tests. These are only available in highly specialized labs. I would never expect to see these results on a patient who's being referred to me. This list includes the Multimers, which help us distinguish type 2 von Willebrand disease, a test called the RIPA, ristocetin-induced platelet agglutination, which can help identify 2B, and then a few other tests that have been described, the collagen binding assay and the factor VIII binding assay, that can help subtype type 2, but actually, as far as I know, are not clinically available in any lab in Canada right now. And if I'm wrong about that, I would love to hear it from the audience. Genetic testing is also available free of charge to patients and clinics in Kingston, and that's because we're funded by the Association of Hemophilia Clinic Directors of Canada. And so if we get a DNA sample, we'll do the testing and issue the report, and there is no charge that is apparent to the patient or clinic. This is what multimers look like, and so we take von Willebrand factor and run it on a gel, and what we're doing is counting the number of bands, and you should have at least 10, and if you don't have 10, that makes us suspicious of either 2A or 2B von Willebrand disease. I've already alluded to the classification a couple of times. There are 3 subtypes, and I'm going to go through them very briefly. Type 1 is the most common. It's also the hardest to diagnose. We often have to do repeat testing, and I was having a conversation yesterday with a couple of colleagues, and we were likening this to blood pressure. You would never diagnose somebody with hypertension on 1 blood pressure reading. We shouldn't be diagnosing von Willebrand disease based on 1 reading. I think people have to have repeated tests because of those variable, those things that can cause variation in levels. You really need to test a few times to get an accurate idea. Blood group O is an important issue here because people who are blood group O have less von Willebrand factor than people who are blood group A or B. And so it's important to recognize that you're going to see a predominance of blood group O in a type 1 population. People always want definitions. This is ours in Kingston. I get my ass kicked for this definition all the time. The Americans don't agree with this definition. They don't like this cutoff of 50% of normal. They've pulled it down to 30%, but this locally is what we use. Type 2, as I've mentioned, is a group of disorders where von Willebrand factor doesn't work right. And 2A and 2B are characterized by lower levels of function than protein. And so if you do that ratio of the Winikoff to the antigen, you're going to see it less than 0.6, and abnormal multimers. The thing that would push you to 2B is an abnormal RIPA, the presence of evidence of increased affinity of von Willebrand factor for platelets, or genetic test results that have identified a 2B mutation. And this is what happens in the peripheral blood of patients with 2B von Willebrand's disease. Their platelets stick together because in between all of these platelets is that mutant von Willebrand factor. And that's why the patients will often have a low platelet count. They often will have thrombocytopenia. 2M, M stands for multimer. The multimers are normal. And so that's what's different between 2A, 2B, and 2M. You're going to see this discrepancy between the function and the protein, but the multimers are normal. 2M patients generally don't respond well to desmopressin. That isn't a hard and fast rule, but subtyping appropriately does have implications for treatment. And 2N von Willebrand's disease, N stands for Normandy. It's the place in France where this was originally described. This can very easily be mistaken for mild, moderate, or moderate hemophilia A. And the problem here is that the factor VIII level is lower than the von Willebrand factor, and it's because the mutations in von Willebrand factor are in the part of the protein that's supposed to carry and protect factor VIII, so it doesn't do that right. Genetic testing can be very helpful here to figure out if the problem is in the factor VIII gene or if it's in the von Willebrand factor gene, and that's critical for treatment because we would use different products depending on the diagnosis. And type 3 von Willebrand's disease, which is what Kouides had, the index case, is basically an absence of von Willebrand factor. And if you don't have VWF, your factor VIII levels get quite low, less than 10% of normal. Genetic testing can be helpful in these cases, and generally the patients are managed with factor replacement or other modalities that can be effective in other subtypes as well, like the oral contraceptive pill. So in that guide we gave you is this summary table that basically goes through what I just talked about, and it goes through the subtypes and what the lab pattern looks like. So I hope I've convinced you that we need to be testing appropriate patients. I think the bleeding score can be helpful to identify those who require additional investigations, but also those who don't need additional testing because the risk of von Willebrand's disease is so low. When you're looking at your results, it's important to know about the patient and the sample factors that can affect your results. And clearly, accurate diagnosis is the first step in effective management of von Willebrand's disease. And so I've already acknowledged Megan and David and Claire, who helped put the guideline together. I want to acknowledge the Canadian Hemophilia Society, who funded some of the research that I showed you about bleeding scores, and the HTCs, who funds the genetics lab in Kingston. Thanks for your attention. So we're going to do questions, Rochelle, or? Yeah. Okay, so if there's questions, I'm happy to take them.
No, not. So we actually have time for 2 questions from the audience.
I've stunned everyone into a coma with the subtypes of von Willebrand's disease. Yeah.
I have a question on transporting. You suggested that we transport at room temperature whole blood.
Yeah, so before the tube gets spun.
Right.
Yes.
Understood. So is there a limitation from taking the blood to length of time before it actually hits the main testing lab?
So it depends on whether or not it depends on whether or not you can separate it into platelet-poor plasma before you actually get it to the main lab. If you locally can separate into platelet-poor plasma, freeze it at -40 or below, and transport it at -40, it's fine.
Right.
But if you can't, you got 2 hours.
From taking the blood to getting it to the main lab?
Yeah. And that's an enormous problem. And so you clearly just get my point, which is that I see patients all the time who've had blood drawn in Kingston. The blood got driven to Toronto. Well, you can't do that. You physically can't do that within the recommended time frame. And you get false positive results, which is really a problem.
So I have a patient in Northwest Territory.
Yeah. Oh, planes, it's the worst in planes. So the issue with transporting plasma is it goes in the bottom of the plane, which you think is cold, but it's actually hot. So even if you froze it, it's probably going to thaw. It's an enormous problem.
So
So you need to ask what's happening with sample transport and whether or not those issues are being addressed. I had a meeting yesterday with Dr. Michelle Schultzberg and Dr. Rita Selby, who are here in Toronto and who often are the ones receiving those referred in samples. I promise you, the labs that are doing this are absolutely aware of this problem, and we've been talking about a study to try to address this. I think you need to know what happens to your sample and if it's being dealt with properly, and if it's not, I think you need to send the patient down. You got to send the patient to somewhere where this can happen properly. Otherwise, you end up not really knowing, does the patient have the disease or not?
So my patient, let me recruit -40 or down there.
Yeah, that's what I'm saying.
Hi, excuse me, Nancy Van Eyck, gynecology from Halifax. I have a question regarding the timing of testing in two specific groups.
Yep.
One is the menstruating woman. Do you suggest doing it at the end of their menstruation so you get sort of the lowest level possible? And the second is the group of patients that are referred to you that are already on oral contraceptive pill, and what do you feel is a significant washout period in terms of actually determining that?
So good, because the answers are a little bit tricky. In terms of menses, there certainly have been descriptions about the fluctuation of VWF levels over the menstrual cycle. If I can, I do try to test during menses, and you're right, the levels are the lowest then. It's also a reasonably easy time for a woman to identify, rather than saying, I want to test on day 10, and how do you know if you had a 10-day period? And so I do try to test during menses if I can. However, the geographic issues in Canada are a problem, and if I have a patient who drove 2 hours, I'm going to test her that day because she came 2 hours. And if I get uncertain about the diagnosis, I may actually have a conversation with her about coming back so that I can get the best read and get the real baseline on her. The issue about the pill is controversial. And I know that Andy James, who's very involved, and Peter from the United States, if I'm right, I believe the statement actually is that you should not discontinue the birth control pill to retest. I have a feeling that that may have to do with the risk climate in the States. Is that right, Peter? So maybe Peter can comment on this for us. In cases where I have borderline levels and I'm really suspicious of a bleeding disorder, I have had conversations with patients and stopped for 2 periods and retested. So you stop the pill, you have the period, you go a month and you have the next one, and I test during that one. And there have been occasional cases where I've clarified the diagnosis by doing that. But Peter, can I impose on you to comment about your practice in the States and your guidelines?
Recent studies have shown that the low-dose formulations of estrogen do not raise levels. Actually, presented Kouides had a paper in TNH that the levels decreased. And so it's with the higher doses, the above 50 micrograms, that there was an appreciable change.
So that's a great point, that it's pill-specific, those fluctuations. Thanks, Peter.
I just want to comment on that same issue. I'm Tanya Zmo. I'm a gynecologist in Ottawa. I did my fellowship in pediatric gynecology here at Sick Kids last year, and part of my research, we did a mini review on this topic on whether you could test for von Willebrand on the oral contraceptive pill, and it was just a review. There wasn't enough for the same sort of to do a meta-analysis, but what we showed in the review is that most of the studies with pills that are less than 50 micrograms, so what we're using now, actually don't show an increase, so that we can actually test, and we don't need to risk taking these young women off the pill and risking, menorrhagia, hospitalization, and transfusion.
Or pregnancy.
Yeah.
So thank you very much, Paula, for that fascinating talk. I just want to make a quick comment about our practice is that we actually don't stop the pill to test, and especially when it's low dose because of Rezan's study, actually. So thank you very much, Paula. Really gives me great pleasure to introduce our next speaker, who will speak to us on pregnancy, delivery, and the postpartum. It's Dr. Peter Kouides, who's an associate professor of medicine at the University of Rochester School of Medicine and the medical and research director of the Mary M. Gooley Hemophilia Treatment Center in Rochester, New York. Over the year, Dr. Kouides has served as a principal investigator on a number of studies, primarily dealing with gynecologic and obstetrical complications of von Willebrand disease. Dr. Kouides is the co-chair of the CDC Universal Data Collection Study of Women with Bleeding Disorders. He is also the president of the Hemophilia and Thrombosis Research Society of North America for a term of 2010 to 2012. Dr. Kouides also has been a huge mentor to me and has been a huge contribution to the field of women and bleeding disorders. And it's with no greater pleasure than we have our guest from across the border speak to us on this issue.
Thank you, Rochelle, and I want to thank you for the opportunity to participate in this first ever conference. You're really setting the bar high for those of us across the border, and I think you'll have nothing but success since you have such great support. You have such medical leaders as Dr. Winikoff and Dr. James, who really have the energy and the expertise to really help guide this organization, as well as many other colleagues in Canada. So it's wonderful to be part of this. And what I'd like to do just as my first slide, and this is more of an inspiration of my colleague Mark Crowther in Hamilton. Often when he speaks, he first shows a picture of the steel mills when you're going to Toronto from Hamilton. And again, I drove, so it reminded me I saw those nice mills there. And it kind of levels the playing field. Like if our dear colleague Christine Lee was presenting here today, she may show first a picture of Big Ben or Parliament, And this kind of just tells you that some of us have more, we set the bar a little bit lower and we have more humble origins. But you know what, I like to brag about this picture because this is where I work. And if you look very closely where that car is, that's where I park. And my office is that window with the light turned off. So I'm in my office in under a minute, literally. And actually, I took this picture for a reason, because that day there just happened to be a beautiful rainbow there. First, I would like to just share disclosures. I always put the most important ones first. Especially since they play in Toronto, it's a little bit apropos. But all kidding aside, really you should look very critically at how one is affiliated with various support. I like to say I'm conflicted, but equally I'm transparent, I think. And this is some of the initiatives I'm involved with that are partly funded through industry and other organizations in that sense. So it's equal opportunity here. There's, I think, every pharmaceutical company that's involved in the care of women with bleeding disorders is listed here. But again, you should really be aware when one is speaking about potential conflicts in that sense. What I thought I'd do for my session is to share with you actual patients, somewhat informal with questions for the audience, so we don't have the actual interactive panel where you have where you could pick the choice. But these are actual cases that in part I personally have learned from. I'm often fond of saying, even though I completed my training 25 years ago, in the US we kind of use this R system, so the intern is an R1, the third year resident's an R3, so I'm an R25. So this is a case when I was an R15, I believe, and it also did give me some gray hairs, which is another saying I'm fond of saying. So this patient would be classic for someone possibly with underlying bleeding disorder that right at the start of menarche, and again, that's a helpful, as mentioned earlier, clinical feature of perhaps underlying bleeding disorder if the period starts since menarche. And at that time, the pediatrician, I think it varies from pediatrician to pediatrician in terms of their comfort level. Using oral contraceptive in some places would be appropriate for the pediatrician to perhaps start oral contraceptive, and this was an appropriate approach to start oral contraceptive, and had decided actually to have the GYN become involved. And along the lines of what's being done in Canada and the US, we do try to reach out to raise awareness. This was a time where we were really at the height of trying to reach out. We were actually doing studies at that time where we were trying to recruit patients who had heavy menstrual bleeding in terms of determining locally in our area the prevalence of von Willebrands. So there was an actual in-service by our staff about von Willebrands, and at that time the mother was also Googling information about menorrhagia and menarche, and learned about her center and really wanted to be seen because of the fact that from her point of view she was very unhappy that the gynecologist had the quote-unquote gall to start oral contraceptive in her daughter.
in that sense. And so when we saw her, as Paula said, it's important to confirm the diagnosis. Actually, one of the favorite sayings I have in our laboratory is repeat until normal, because studies have shown in the United States that 75% of the time on retesting, when it's a sample that was from an outside lab, these are very good labs. I mean, Mayo Clinic, I bow down to them. The other Rochelle, Minnesota. I mean, they do 80 recoffs a day. I do that much in a month. And yet they will have falsely low levels because of these various transport issues that Paula talked about. We'll refer to as a milk box diagnosis of von Willebrand's. That sample's been left in the milk box waiting for someone to pick it up for about 6 hours. And then the platelets are picking up the von Willebrand, absorbing and lowering it. So it's very important that you confirm the diagnosis on site, where you can process a sample within an hour or less, ideally, and spin the sample and then analyze it in that regard. So we did confirm the diagnosis, and again, even if she was planning to stay on oral contraceptive, it's good to know what is her baseline response in case years from now or a few years from then she's going to need her wisdom teeth out, and I would think about giving her intranasal DDAVP, and I'll have that information, because at least in Rochelle, New York, the wisdom teeth seem to come out on a Friday afternoon, and that's when we get the call, like Friday at this hour. So if my phone goes off, it may be for that. So we'd like to have that information in hand in that regard. And again, unfortunately, you can kind of see where I'm headed here, that the mother wanted her daughter to have the intranasal DDAVP, given her concerns about her daughter being on oral contraceptive. She did well using the intranasal DDAVP, 1 puff each nostril, first 3 days of her menses. And then we received a phone call about this issue here. So again, I was an R15 then. I learned my lesson that, yes, I can have a very nice, academic letter that I can put out about this patient, saying that, we've uncovered von Willebrand's as a cause of her heavy menstrual bleeding, and that we advise, hemostatic options are as follows: intranasal DDAP. Yeah, what I didn't do is pick up the phone and talk to her pediatrician and learn the fact that, unlike my case, the pediatrician took the time in a private setting to learn from the patient that she was sexually active. So I really dropped the ball at that time, because if I really had asked that appropriate history, I would not have advised or really condoned the use of intranasal DDAP, because oral contraceptive does have, at least probably about the same efficacy rate as intranasal, though someone may argue intranasal may be a little bit higher, but intranasal probably has more side effects than oral contraceptive, in terms of the fact that, at least in the States, about a quarter drop out because of headaches and fluid retention, though I realize there's issues with oral contraceptives also. So at that point, the issue came up where the mother was actually wanted her daughter to consider DNC, and they were at that point of planning, DNC. So that's, one of the questions that did come up initially with this patient is, what would you tell, the mother? And this is kind of a trick questions. I'm fond of doing this with our residents and fellows, because I think most of the audience would say, well, I mean, number 3 is probably the answer, because we're here to raise awareness that, postpartum hemorrhage, heavy menses does occur. But it turns out, if you look in the literature, and I'll share that in the upcoming slides, the initial reports were probably overestimates because of selection bias. And actually, the real choice would be number 2 in that regard. And again, I'm kind of preaching to the audience here. People realize that, as the British are fond of saying, in most cases of von Willebrand's, which is primarily type 1, there's gestational palliation occurs, by the 3rd trimester. As you can see, initially those levels don't rise, And in that regard, colleagues have clearly reported that if indeed we did not take precautions in that first, trimester for DNC, we are expected to see, excessive bleeding. And sometime in the third trimester, we start to see a rise. Now, that's not cast in stone. Occasionally, we will, assay one's levels in the second trimester and note to our pleasant surprise that they've already increased. The sooner the better, at least medical legally in the United States, where we can use that information to tell the anesthesiologist that they can have, they can give an epidural, and also in sharing this with the obstetrician and not worrying about immediate risk of hemorrhage from the von Willebrands during active labor in that regard. And we're presently completing a study that is very methodical, where we're matching matched women with von Willebrands, primarily type 1. We've just reached our 40th patient, so we've closed the study. This was funded in part through CSL Behring and led by Dr. Andy James, where it's amazing that we have so much data where we're sampling not only 36 weeks your von Willebrands levels, but then right at the time of active labor, and then 4 hours later, 12 hours later, 24 hours later, 48, 72, and then weekly for 6 weeks. So we're coming up with very interesting curves, and that will be presented in part by Dr. James at the World Federation of Hemophilia meeting in Paris in 2 months. And I'll also share with you some data that preliminarily that seems to suggest that, levels are, adequate for the first 24 to 72 hours, but, they certainly will fall after that in that regard. But certainly, because they can fall somewhere between the time of delivery to 72 hours, the patient is at risk for postpartum hemorrhage, primarily secondary, but also primary. And historically, the reports have suggested that up to a quarter to a third of women with all types of von Willebrand are at risk of postpartum hemorrhage. And certainly a number of these patients have needed blood transfusions. But again, and some of this is our own data, and trying to be transparent here, it's not the greatest data because there's a selection bias. Even though we try to approach all our women with von Willebrands, if we're looking for those who, if we ask them about did you have heavy bleeding at delivery, the way the question's asked, and since we don't have very good quantitative tools often to use, this number is probably historically an estimate in that regard. But it's a real problem in that sense. Certainly with other bleeding disorders, it's similar, like von Willebrands, up to a third. With the platelet function disorders like Glanzmann's and Bernard-Soulier, it's been reported up to a half can have can experience postpartum hemorrhage. And I can add as an aside, we can make these slides available if people are interested to look at this afterward in that regard, because I don't know if this was printed out as a handout. But probably the best estimate of how common is postpartum hemorrhage comes again from our colleague Andy James, who looked at this very large U.S. inpatient sample database that contains over 16 million pregnancies, over 16 million of which 4,067 were coded with von Willebrands. And sure enough, women with von Willebrands were more likely to experience both antepartum as well as postpartum bleeding. And again, it's not to the odds ratio you would expect from these prior studies, though. Again, you could argue there's maybe, obviously there's a problem with these types of studies, that it's, there's a coding bias, and it's, it's not a true prospective study, so this may underestimate it while the other studies overestimate it. So the truth is probably in the middle, that probably about 10% of women with von Willebrands will experience PPH. In this study, it was 6% compared to 4%. That was statistically significant, and more importantly, there was a higher rate of receiving transfusions. And I'm sure many in this room would attest to their own personal experience that they've needed transfusions, and it's natural. In this day and age, unfortunately, at least in the United States, I mean, I had a patient who had a C-section, on Tuesday. And yesterday, she said, they're trying to tell me I have to leave the hospital. That these people have a longer, hospitalization for childbirth, in that regard. And then certainly, what we have to reckon with, and what's important as your organization goes forward, is you try to frame the importance of this issue is in terms of maternal deaths, and that is of concern that there was higher maternal mortality. And I welcome you to read this article in its primary form in Thrombosis Hemostasis, very well done study. And I'll be talking in the afternoon about a U.S. surveillance study that we're doing throughout the U.S., trying to collect such data prospectively as we go forward. But again, what makes it very difficult in coding these cases of did the person really bleed from von Willebrand's, and don't get me wrong, there certainly is a finite rate of it, is that like a lot of medical issues, it's multifactorial, there's more than one cause. And again, if I'm teaching my residents and fellows, I say, remember the 4 T's of why someone could bleed, and often it could be more than one reason postpartum. And certainly a big one is uterine atony, as well as retained placenta. And sometimes one can have multiple issues, and then the lack of thrombin, which fundamentally that's what von Willebrand's is an additional one. So a good physician in general should always consider more than one possibility. And sometimes we have patients who tell us that, they bled with their first pregnancy in the setting of von Willebrand's, but they also recall that, the obstetrician mentioned how, weak the uterus was, and they were really pressing on it to massage it because they were starting to bleed afterwards in that sense. So back to our case, the patient did decide to keep the pregnancy. I'm happy to report that 2 months ago she had her second child. 10 years later, has settled down, gone back to school, and everything has turned out well in that sense. But with this pregnancy, more unraveled as the case went on. At her age, she had a dental abscess, and as we expected, her levels would not have risen by then. And so the question now for the audience is, what would you advise? Would you give her DDAVP, or given concerns for DDAVP as outlined before, below, based on some case reports, primarily from Juan Chediak in Chicago, where he had several patients who had these potential adverse events. Again, it's not convincing that it was definitely attributable to the DDAVP. Is it safe for you to receive DDAVP in the first trimester? And so I would say here that it is, because of the fact that DDAVP really binds mostly to the V2 receptors, and it's really the V1 receptors that mediate the vascular tone that can lead to decrease blood flow and contractions in that sense. But that's all in good. That's more theoretical. We need some data, and I'm happy to report our colleague Razan Kadir had a associate, Derry Trigg, work on this systematic review of the literature, where they have since looked at a number of case series that have reported the use of DDAVP in the first trimester. And it's encouraging in these studies, including a series from Pierre Minucci, who probably is the only one who can, is the only author, write a letter to Blood and get it right in, that I gave it to 32 women for chorionic villus sampling in the first trimester. They had no bleeding. It gets accepted. That's it. End of it, But besides his experience, others have since reported the fact that primarily for von Willebrand's, if DDAVP has to be used in the first or second trimester, in this case for her wisdom tooth extraction, there weren't bleeding events. I'm going to kind of skirt around the issue of antifibrinolytic therapy. That's fortunately not a category C, but it's not clear how safe that is. In select cases, we have used it, in pregnancy, but it's important that we, collect some more data about that. So I think, this is encouraging. And again, I refer you to the top citation. Is a very nice review that appeared earlier this year in hemophilia that does, give us some confidence to proceed ahead. Well, the case continues because pregnancy is not a static process, of course. And at this time, the mother who had us on speed dial reached us about this issue. And this is a typical Rochester reaction. We believe that about a quarter century there was a case of epidural hematoma, and then, as you know, there are some reports with enoxaparin being related with a black box warning. So there's a lot of concern about that. In that sense, and in general, our obstetricians are quite hesitant to clear, to have somebody to go ahead with an epidural if, unfortunately, they're labeled with von Willebrand's. And this just happened 3 months ago. A family I take care of, the daughter's now in Binghamton, New York, about 3 hours away from us. We did send a letter clearing her because her VWF levels were checked in the 3rd trimester, and they were, above normal, and yet the anesthesiologist refused to because I was not on site, and I couldn't reassure them if something happened, we could prevent the bleeding. So that's how she remembers, that's how at least the mother of this, patient remembers the daughter's first delivery, that, it was awful that she couldn't have an epidural. So that's what we're often up against. And again, the answer in this case would be that certainly if the levels are below 50, we would want to cover that person, with hemate P or whatever is available, whether it could be alphanate or willate in that regard. I should have made this, I was not politically correct here, so I apologize. But any of those would be the, treater's choice to use. And again, there's now, fortunately, to counteract this historical observation of an epidural not being offered to patients is that there now have been a number of studies, and again, the best one comes from Razan Kadir's group with Claudia Chi, who had looked at their experience, as well as collated 12 case reports in several series that have shown that if you can demonstrate, particularly in von Willebrand's, that in the 3rd trimester the levels have normalized at least above 50%, that such a patient is a very, very low risk for hematoma. Does it mean it can't happen? Well, certainly in pregnancy those epidural vessels are engorged, right? Because in the 3rd trimester, as a patient is flushed and you have the hormonal surge and vasodilatation, you can have dilatation of those vessels, and the needle could nick it, so it still could happen. But it's reassuring that in women with inherited bleeding disorders in general, if their levels have been shown to normalize, and if you see in the middle one, these were women who had a normal levels, 12 had von Willebrand's, 10 were carriers, that they did not have any issues. It stands to reason, it's understandable, the ones who they did not clear for an epidural without doing something prophylactically were those where the levels don't increase. We know, unfortunately, factor 11 doesn't increase. Factor 7 increases variably. Kulkarni et al. With Kadir also showed that in some cases it can increase, and we've had one family where the levels of factor 7 do go up to what we feel is a hemostatically safe level above 30 to 40% at delivery, but that's not always the case, and we know factor 9, hemophilia B, may not, and platelet disorders it may or may not. Our colleague Mike Macris had a case where of a storage pool disorder where they did look at platelet function. It did improve, and they cleared that person, without problems in that regard. And then there's actually even more issues that can come up in a case like this, where the obstetrician may ask, "What about double uterotonics?" This is a suggestion that's evolving now as we're looking at trying to reduce the risk of postpartum hemorrhage. Perhaps we shouldn't, perhaps oxy shouldn't just be given, but you should, augment that. I don't know how often you use, both at the same time in perceived cases of high risk for postpartum hemorrhage. Rochelle and I have been part of a consensus group that is looking at recommendations, and this would really be not even a 2C recommendation, but a level 4 in terms of consensus. But it'd be nice to start looking at cases where that is used, double uterotonics, where you're giving oxytocin as well as per rectum misoprostol in that sense. And the other question that comes up, if it's a boy, well, she did have a boy. Again, they asked us, about a circumcision. And in general, that's not an issue. Even if the mother had type 3, the child should have adequate levels. And if the mother has been demonstrated to have normalization of her levels, some of that's going to come through the cord and would be okay. So we don't make a big deal about that in that regard. And then another issue that comes up, and perhaps Paula later could talk about her own experience, where I believe in Kingston you often, I don't know if you discharge the patients on oral, on tranexamic acid, all patients, or just high-risk ones, so you individualize. But that's something to consider. Though sometimes the issue comes up, is it safe for breastfeeding? It does seem to be, safe for breastfeeding. So in someone particularly at high risk, perhaps a type 3 patient or a other bleeding disorder patient like a severe prothrombin deficiency or factor 7 deficiency, you may want to consider, in that regard, using using tranexamic acid. And there's an ongoing national study that's looking at that. And again, this is a reminder that the levels do fall somewhere between the time of delivery to about 3 to 5 days out. And that's what we're seeing in our U.S. case control study, and what our HOOC with Razan Kadir recently reported in the journal Hemophilia this year of the levels going down. In the remaining few minutes, I'm just going to quickly present these cases as a show and tell of what you would do in this situation here. In terms of, this is an older patient, and in her case, she did suffer postpartum hemorrhage. It was unclear of the circumstances at that time. What other obstetrical issues were there? Was it atony on top of this, or retained products of conception? Was it an outside hospital? The records were not easily obtainable, and the caregiver was no longer practicing. It was unclear the circumstances of that. So that's what we're left with. We knew at that time she had a level of 47%. And arbitrarily, because she wasn't quite at that 50% number, she was advised to deliver at a hospital, but she ended up delivering at a local hospital. This is not to say that at a university hospital she would not have sustained postpartum hemorrhage if indeed the cause was atony or retained products. But the question in this case, what would you counsel her? If her levels are above 30, can she deliver at the community hospital? This is an issue if you're at the Northwest Territories, of course, for example, or if the levels are above 50. Again, this 50 is somewhat of an arbitrary number. We do know, though, in general, that the bleeding score seems to correlate with the level. So the lower the level, the higher the score. So I think there's some credence to this. But why, can it be 40 as opposed to 50? Or, again, that's somewhat arbitrary. I think in this case, we ideally want her to deliver on-site at our center because of the fact that she did have this prior history of postpartum hemorrhage. It wasn't clear of the details, and the last time her level was a little bit low, 47, and we wanted to recheck this. But there's not clearly a right answer here. But as part of the guidelines that were promulgated by the NHLBI, this was a recommendation that you can deliver, above 50%. And again, in the interest of time, we can have these slides available. In this case, this person unfortunately had an adverse reaction to desmopressin and became very hyponatremic. And again, the question here, one could say that she should use prophylaxis if her levels are below 50, but because, she had the DDAVP and had a reaction to it, you probably, even if she's, you would give her, a concentrate. And then, again, the study that I mentioned, this case control study, we've also been looking at the course of these people. We're checking their levels so frequently. And it's very interesting that, we've accumulated a number of patients who are under 50%, and there's some interesting information on how they were treated in that sense. So in general, you could try DDAVP if they're a type 1 who've responded in the past, but in this patient's case, we're going to avoid it because she has become quite hyponatremic in the past from it in that regard. And again, these are some guidelines from the UK. for that one could look at. And again, I can share these slides with you, and I'm just going to quickly go through this, point out this very nice study done from the Dutch last year. They showed if you had more severe von Willebrand's than type 1, about up to a third did have postpartum hemorrhage, and they did apply the bleeding score to kind of double check that, and they showed that the levels did correlate inversely with the score. And this last bullet is a concern because that's what we're seeing in our own studies, that we're probably under-treating the women who really need treatment. And I will just, in the interest of time, just quickly mention that there are some ongoing studies for severe postpartum hemorrhage, like that quick picture that I showed you, that are ongoing. This is for postpartum hemorrhage in general in the obstetrics community. There are some interesting studies, particularly looking at the fibrinogen concentrate, because the low fibrinogen seems to, increase risk. So I will stop there because I believe I'm over time. Thank you.
Thank you very much, Dr. Kouides. Just if you don't mind staying, we have time for 2 questions, short questions preferably. Can you go up to the microphone, please? I can't see.
Thanks for a great talk. I'm Dr. Seidenberg from Ottawa. Since we're here to empower some patients as well, I just want to share some experience that we have from our clinic in Ottawa, which I think my nurse Lucille Cass would agree happens to be the most fecund group of patients with bleeding disorders, possibly anywhere in the world. We have pregnant patients every month. So one of the things I would encourage you to think about is we have a pretty stock letter that we send when we see the patients around 28 weeks, and it says what our recommendations are based on what the levels are. We send a copy of that to the patient's obstetrician, to labor and delivery at the hospital where she's going to deliver, to the pre-admit unit where we encourage them to see an anesthetist beforehand, and we send a copy to the patient as well. And we tell that patient, make photocopies of this and put one in your glove compartment and in your wallet and in your husband's wallet and everything, because should you present to the hospital without this letter, there's a very good chance someone may not know what to do, may not wish to give you an anesthetic if you wish to have one, and it has my name and how to contact me or my colleagues in hemostasis at the bottom. And the patients have found that very encouraging, but also the business of having them see an anesthetist prior to their scheduled delivery, because the anesthetists are often very wary and uncertain, and this gives them an opportunity to have some frank discussions about the use of epidural. Also, the other thing that I'd be really interested to hear your opinion on, Dr. Kouides, is one of the problems that we've encountered is our patients become very dependent on us for some of the reasons that we've heard, that they haven't been adequately heard out prior, and we get calls when they've gone home and they're bleeding through more than a pad an hour. So one of the things that I'm very adamant about telling my patients is, if you go home and you're having excessive bleeding, vaginal bleeding, and you're dizzy or lightheaded or soaking more than a pad an hour, it has to be assessed by an obstetrician first, because it's been our experience that 9 times out of 10, it's an obstetrical problem and not a bleeding disorder issue, and we're happy to help out when we can, but this must be assessed by an obstetrician. So I'm glad that we have some obstetricians here who are taking an interest in this, and I think it's really important. It's been our experience that those have been really important communications.
So thank you for all those comments, and I think that those are all very good points. There might be some different legal issues, as Peter was pointing out to me, in the U.S. that might not be favorable to sending letters to patients at home. That being said, the multidisciplinary panel this afternoon, if you're all there, we'll have a lot of forum for discussion on those things that are very practical and useful. Just one last short question, please.
Yes, as an obstetrician of very little brain, if you could tell me a little bit, I've got to consider our little baby as well in there. Are there any procedures that I need to be wary of on my end in caring for a woman during labor that may affect baby as well? I'm thinking things like scalp sampling, vacuum delivery, stuff like that, patient with von Willebrand's disease.
That's a good question. I think analogous to the situation I mentioned of circumcision, that baby's risk is exceedingly low because the levels usually are, adequate. So I'm not aware of that being a problem. I haven't seen that in any series of instrumentation, being an issue.
Thank you.
Thank you very much, Dr. Kouides. This is for you.